Okay, perfect. This webinar does have closed captions available, so to enable them on your screen, you'll simply click Show Captions at the bottom of your screen, and then you can change the settings as well in that button. We should have the Q&A feature enabled for this, but also feel free to send your questions in the chat if that is easier for you. But to submit a question using the Q&A, you'll select the Q&A icon at the bottom. You can also choose to send questions anonymously through that Q&A feature if you would like. And we will also have a Q&A session at the end. So if you throw your question in the chat or the Q&A and it's not answered right away, I'll be keeping track of all the questions and we can make sure that those get answered at the end. Please be sure to follow us on our various social media accounts to keep up to date with the newest information and events. A link to complete an event evaluation will be put in the chat at the end of the webinar as well as via email. Please complete this as it helps inform future presentations. It should take less than 5 minutes to fill out. Archived presentations and a list of upcoming events can be viewed on our website. And if you experience any technical difficulties during this presentation, you can contact updates@hcet.org, or you can send myself or Megan Arias a private chat. Nursing contact hours are available for this presentation. So in order to receive those, you must attend the entire webinar, return a completed participant evaluation and post-test, and then complete the nursing contact hour form, which I will send via email following the webinar to kbradford@hcet.org. No one in control of the content of this webinar has a relevant financial relationship to disclose within an eligible company. And now I'd like to introduce you to your presenter for today. Lillian Rivers Kelly is the Director of Housing for Horizon House's supportive housing program in Indianapolis, Indiana. She is responsible for providing oversight for the housing team, which includes housing retention specialists, intensive care managers, and supervisors. She establishes and maintains relationships with community providers and is responsible for the data collection for her team. Her educational background is in social work, earning a bachelor's degree and master's degree in social work from Indiana University, Purdue University at Indianapolis. She has worked with various housing programs in the past 12 years in direct services as a case manager and as a supervisor to a multidisciplinary team of staff. Lillian has a passion for housing and ensuring services are delivered within a housing first, strengths-based harm reduction framework. And without further ado, I will be turning things over to Lillian.
Hi, everybody. Thanks for being here today. I love a multidisciplinary approach to things. So I would love if you would tell me where you are in Indiana and what your profession is or what role you're working in. I'd love to just see where people are coming from and what kind of work you're doing. So one exciting thing is I've actually had a promotion since this was made. And so I'm the VP of Housing at Horizon House. I want to tell you a little bit about Horizon House just to level set so you know where I'm coming from. So Horizon House is a multi-service day center here in Indianapolis, serving those who are unhoused. So in our service center, it's not overnight. People can get mail, take showers, access laundry, access case management services. There's an employment center. We offer food as people are exiting. There's clothing, basic needs items. And we're working toward making it a housing hub so that it's a one-stop shop. So we are partnering with many different providers within the city of Indianapolis to bring people in because it's a barrier to have to go all the places to get all your needs met, like getting an ID, which you need for housing. We also operate what is called professional blended street outreach here in Indianapolis, and that is working with folks who are living outside unsheltered. And we work with many different agencies, including the VA, probation, IMPD, Eskenazi Health, Damien Center, many different providers, so that when people are out on the street, there's a coordinated effort to know who's out there, know what their needs are, and try to get them connected to the needed resources. We now have nurse practitioners going on street outreach, doing street medicine, which is very exciting. And then, of course, housing, which is what I work in. And so there was a bit of an overview, but I just want to also share. So we operate scattered site and site-based, which means we have people living all over Marion County in apartments or homes. And we also operate 2 buildings. So we have almost 300 households with almost 400 people in those households. About 20% of who we serve are families. And supportive services means there's a disabling condition. That means someone has a mental health condition, substance use disorder, chronic health condition, and that they've been homeless a long time. So it's a bit different from some of the other programs that operate where it's called rapid rehousing, where it's short-term intervention. Someone just needs help getting in, maybe a deposit, and moving on. We do wraparound, consistent services for long periods of time. Thank you all for putting those in, and it looks like things are kind of all over the place. So shout out to my fellow social workers out there. And I also wanted to mention my concentration was in health when I was in school, and so I really love the interaction that health systems have with people who are unhoused and other vulnerable populations. And really what buoyed me into working with people who are unhoused was working in the emergency department. And I just really needed to get my hands much more dirty than I could in an emergency department. So that's just a little about myself. Thank you guys so much for putting your info in the chat. And I'm really glad Jordan's going to keep track of questions, because I'll get derailed if I start engaging with the chat. So again, thank you. Okay, let's talk about what I hope to accomplish today. So I really just, you all are experts in trauma. You're all experts in the fields you're in. And my guess is there's lots of overlap with people who are unhoused. So I hope that there's a deeper understanding of the impact of trauma, specifically to folks who are unhoused or experiencing homelessness in your areas. I hope that there's an awareness of special considerations for this population within the healthcare system, maybe things you haven't thought of before, and then really applying trauma-informed principles to this population. So hopefully we get some of that accomplished today. So this slide hopefully is pretty self-explanatory, but really the trauma, it's the fact that trauma and homelessness go hand in hand. Not only can one experience homelessness as an outcome of a traumatic event or a response to trauma, but experiencing homelessness can and does cause trauma. So it's cyclical. So those who study trauma and what their long-term consequences are acknowledge that homelessness can be a consequence of trauma. In my over 15 years serving this population, in many different ways, outreach, case management, housing, I have never served anyone who didn't have events that one would consider traumatic in their past. Many things that led to health consequences as well. So none of this is surprising to me, and I hope none of it's surprising to you, but there's a correlation between trauma and homelessness pretty clearly. Next slide, please. So again, homelessness can be an outcome of trauma, but then homelessness is also a trauma. So I want to share a little bit. So picture being served papers and attending eviction court because you couldn't pay rent. There are over 209 evictions filed per day in Indiana, and Indiana makes the 5th highest eviction rate in the US. So evictions are one of the biggest causes of people experiencing homelessness, affordable housing. And so, yeah, picture going to eviction court. You're told you have to be out in a certain amount of time. You go home, have to think about all the possessions you have and whether or not you have the means to put them in storage, or whether or not you have to cut and run. And then imagine if there are children or pets in the mix, figuring out where you might go from there. So there's a loss of community you might have friends who are all housed, and there's a shame with losing your housing. You might lose all of your possessions. When eviction happens and people don't move their items out of their home, there's a packing company that comes and removes all those items and puts them in storage facilities. And then the landlords work with them to store them for a period of time. And then people have to pay an exorbitant amount of money to get those out. Often people never see those items again because they couldn't pay their rent. They probably can't pay to get their items out of this pretty pricey storage. There's ongoing fear, loneliness, despair. You may have lost your network of people who you're working, who you know. There might be job loss because of it. So everything is new. It's a big change. It's grief. People who are living unsheltered have a high chance of experiencing physical violence. I've never worked with a woman who was staying outside that didn't experience sexual trauma, either because she had to do things in order to have protection in the place she was staying, or because she was by herself and she was taken advantage of. People get assaulted and robbed. People are have their items stolen frequently. And then there's this constant moving. So it's either going from shelter to shelter because a lot of shelters don't allow you to stay long term, or moving from camp to camp because there's a reason you have to move, whether or not it's not allowed to camp in that spot, or someone has come that is not comfortable for you to be around, or people couch surf. And a huge number of people, so HUD has definitions of what homelessness is. And so I think a lot of general population think of people who are unstably housed as homeless. So HUD doesn't actually label you homeless if you're couch surfing, but those are where the majority of the families with children are. And so I think I saw a school social worker on here. And so there's probably many families at schools who are unstably housed, which means they don't have a place that they are consistently going to. They are doubling up, staying with friends and family, which also then puts those families potentially at risk because sometimes there's rules about how long you can stay with somebody. So there's just question mark, instability. And then people find it shameful to be homeless. And so there's that piece of it as well. Let me make sure I didn't miss anything I wanted to say on that. Okay, next. So we've talked about trauma and homelessness. Now let's talk about health and homelessness. So many of you, so the pandemic, COVID-19, during that time, many cities and communities did non-congregate shelters. So there were hotels that were empty because no one was traveling, and they converted those hotels into non-congregate shelters so that there would be less transmission of COVID-19, because you all know, if you're in a congregate setting, picture 300 beds in a local shelter, there's much more increased risk for flu, TB, Hep A, COVID-19. And so that's pretty significant. A kind of jarring stat, and this is from 2019. So but that was the most recent I could find with the National Healthcare for Homeless Council, is that people die on average 12 years sooner than the US population. And that is something I know all too well. This is pretty anecdotal and not based in any kind of evidence, but I'm going to share it anyway. So those of us who've been around for a long time and have worked with people who've been outside for a long time, when they finally get housed, after being outside for years and years, and then die soon after finding that housing, we often think that lots of people say, like, but they were finally housed, like they could settle in, they could address their health needs. And what we've always talked about is no, it finally caught up with them. They were finally able to relax enough to pass away, that the fight actually kept them going, the day-to-day fight of trying to stay alive. And I think we say this to make ourselves feel better, but that the people at least had the safety and dignity to die inside as opposed to under a bridge outside. Because sometimes it just feels like it's too late. So this also illustrates that homelessness makes current health problems worse and also causes new ones. So again, cyclical. So imagine an injury or illness causes a job loss. That then causes housing loss. The loss of housing makes managing that said illness or injury harder, and probably makes it harder to recover fully to then get employed and then get housing again. So that's why I believe people say housing is healthcare. Next slide, please. So some special considerations that I think without thinking about it, without awareness, without fully understanding what people are potentially experiencing before they come to a doctor's appointment, some of these things might not be considered. So when someone's staying at a shelter, their ability to consistently bathe, to keep bandages clean, to access new or clean items, there's an increased risk of infection. There's not access to consistent hand hygiene or running water, potentially, if someone's outside. So wound care is a significant consideration and how someone might care for a wound. There might not be access to refrigeration for meds or safe storage, which then someone could have their medication stolen. So the idea of med management, and then also people having compliance with their medication. Also, inability to control when and where your next meal is coming from. Food available at soup kitchens and shelters are often, they're made in bulk. And so they're often really high in sodium and other items that might not allow someone to meet dietary restrictions based on their health. So again, the loss of meds or theft of meds makes taking medication properly pretty difficult. There's also the idea of sleep. Sleep is a healing thing. Sleep is one of the things that makes it possible to recover. And so the inability to have uninterrupted sleep or deep sleep is not really conducive to healing and rest. I worked with a mom who had a small child, and we worked with her very closely, really to try and avoid her losing custody of her child. But some of the things that she would do is her daughter kept getting ear infections, and she would take her daughter to the ER, and then they would sleep in the emergency room waiting area, or her daughter would, and she would hold her daughter all night, staying awake because she didn't want anything to happen. She also needed to be awake if anyone asked her to leave, which they didn't. I think she and the security guards had an understanding. But she just never slept because she was so worried and concerned to ensure that her daughter was safe. Same thing when she had somebody allow her and her daughter to stay at their house. She stayed awake because she did not want the things that happened to her as a child to happen to her daughter. So add on that she was going to get Suboxone every single day at a clinic. And so somehow this woman managed to do it all. And I won't get into her entire history, but she was so on edge and so frustrated and also so scared that we were going to make a call. But we assessed the safety of her child, and man, if her kid was really, really safe. So I just wanted to mention that. So you guys are already doing trauma-informed care, is my guess, because otherwise you wouldn't be here. And so I want to talk about ways that you're already, what practices you're already doing that are working. And if you're aware that they're working with this population, or if this is new, but you're connecting that, oh, this would work with these folks as well. So I would love, if possible, if people would come off mic or put a comment in the chat. I'd love to know ways in which these practices are already being done in your current setting. And I realize we have lots of different settings on this call. No, nobody brave enough to say anything. Okay, so let's talk about, love it. Okay, so I can highlight some of these things. So oh yeah, that's awesome. Ooh, there's some great comments. Okay, so I want to hit on that a little bit. So taking extra time to listen, absolutely. There's a lack of trust with particularly this population, and an edginess of like, are you going to fully see me? Are you going to fully serve me? Are you going to listen to my concerns? And so absolutely taking the extra time. I want to read some of these though. I didn't think through how I was gonna integrate the comments, but you guys are doing amazing work already. Okay. Okay, I'm gonna pull up some of these and mention them. The stop terminating care for missed appointments is phenomenal because access to resources, access to regular phones is a real thing. And I super applaud you for that. If where you work has the ability to have some wiggle room when it comes to compliance with appointments, that would be phenomenal. Yes, resources are wonderful. Taking medicine out to the streets, meeting people where they are, hygiene kits and food is awesome. It's great to have that kind of as a part of trauma informed care is a universal assumption. And so if you are doing all these things, it doesn't add an extra layer of somebody having to tell you. It's, oh, there's food available, I can have it regardless of what's going on. Immunizations, that's wonderful. Going out into the community, warming centers to discuss mental health and substance use. That's awesome. The more folks can go out to meet people where they are, the better at this point. Wound kits are phenomenal. That's wonderful. Social work, yes, 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 always. Awesome. You guys are great. So what is there that is maybe a barrier in your current space where you can't do something different?
While folks are thinking, Lillian, I'm happy to do this, or if you want to do it, just so that we have everyone's comments for the recording. If you want to read them out as they come in, that would be awesome. I can do that too, whichever you prefer.
That'd be great. I don't know that I can keep track of
Yeah,
it.
I can do that. I see Adam says rural with few resources, offering IDU kits in our county, just needle cleaning. Cindy says we are fortunate enough to have a social worker and we have volunteered with Street Angels in the past. Brittany says if funds are available, I highly recommend power banks for patients who need to charge their phone. Having a working phone greatly impacts healthcare, appointment reminders, phone visits. Christine says our biggest barrier is there are no housing resources in our rural area. I'm seeing other folks say few resources. County does not allow us to provide things that promote living outside, like tents. And someone else said bound by apartment guidelines for shelter units, criminal background restrictions.
Heard all those things. So I just want to comment on lack of housing. Yes. And so I think one of the biggest things just for people to know, especially in rural areas, is the need for housing far outweighs the amount of housing we have. And so even in Indianapolis, but I will say if you're not aware of the coordinated entry system in your area, that you get aware of that. Coordinated entry is the way in which people get access to eligible housing, and the continuum of care is in charge of that in Indianapolis. The balance of state is in charge of that for the rest of the counties in Indiana. So balance of state is the language, and coordinated entry. So usually the point of coordinated entry is that there's no wrong doors to housing. So there are agencies probably listed where you can go get a housing assessment. Yes, and the cost of housing greatly outweighs the ability for people to have housing. So we're employing, not we, some people within Marion County are doing housing diversion tactics, because sometimes people are able to actually double up and be successful. Housing authorities are a challenge. Rural counties actually might have a little bit more wiggle room than Marion County does with their housing authorities. So I love that the barriers are outside of where you are. They're not within that, like, you're still able and willing to serve folks within a trauma-informed lens. It's access to additional resources that seem to be the problem. Sorry, Jordan, I know there's been more comments made.
No worries at all. I'm glad you stopped to comment on them. I think where I left off, more folks said criminal background restrictions. Not all areas have a housing authority either, which leaves vulnerable patients at the mercy of unethical landlords. Very little housing in our area, being in a town or county that doesn't want to believe or see that we have a homeless problem. Yeah, the not in our backyard, folks. More housing is built, but there are still strict rules. Even in permanent supportive housing, the same barriers that made them difficult to house get them kicked out. And then it looks like,
Holly, preach.
pardon?
I said preach, Holly.
Absolutely. And then it looks like Abby put a link in the chat. Balance of state for Indiana, regional structure, coordinated entry is very important.
Yes, thank you for that resource, Abby. And I didn't think to put in the link for coordinated entry, but I can find that. So you all are doing wonderful work, and realizing that so many barriers and limited resources exist. I think being creative in your solutions is great, and I saw some creative things being mentioned. because there are simple things that can be done. I am very curious about the charging places. I know you can charge your phone at libraries and things like that. And there's definitely places where policy kind of dictates what you can do, and I want to acknowledge that as well. Somebody, I'm guessing, in a rural community talked about inability to give out items that encourages camping. Heard and understood. And I think part of what I'll say, and I don't know that this has been said yet, but in earlier slides talking about kind of what people are experiencing, I don't see any kind of choice or control. There's no control over things. And not a lot of choice. So not getting to choose what kind of clothing you wear. Maybe you go to, I mean, even at Horizon House, our clothing pantry is upstairs, and people tell us what they want and we give them the items. Back when I was an intern many years ago at Horizon House, I always asked people what their favorite color was, because I couldn't stand that they couldn't pick the items out themselves. And because I was an intern, I had extra time to actually make sure they liked it, but not like wearing uncomfortable clothes or clothes that might not express who you are as a person. That might seem like a really minimal thing, but that's pretty, when it all piles up and you don't have a choice in what you're eating, you don't have a choice in what you're wearing, you don't have a lot of choice or a say. And so I think being someone who can engage people in, I know my favorite experiences with my primary care physician, who is a DO, has been when she engages me in my treatment options, when she engages me in, hey, this is why I want to do a certain thing. Let's talk that through. And I understand I have a master's degree and I might look like a very different patient than other people. But the more people are able to collaborate on their care, which ding, ding, another trauma-informed principle, collaborate on their care, have choices, have options, kind of be the expert on their own lives, the better it'll go. And it also trying to game plan with the person. If you're aware of the barriers they're experiencing, you know, if there is a barrier with a refrigerator and a medicated item, game plan with them. Say, what can we do to, like, this medicate? Or, and I'm not a physician, so I'll say that, is there another kind of medication I can give this person where that might not be as big of a, where there's no barriers? So I think kind of thinking of all those things is really important. And I also want to mention, you know, I've worked with some really challenging folks over the years who I believe, and they're challenging because they've been challenged and they've been experiencing tough things. So it's that lens of asking what's wrong with you, instead of what happened to you. And a couple of people come to mind when I think about that, because they've been really challenging. We worked with a woman who had schizophrenia, not often treated, and drank a whole lot. And she would go to the ER frequently. And there was a time period where she was complaining of stomach pain. And we saw it. She went to the ER. They metabolized to freedom, so sobered her up and sent her on her way. I know she was really tough. I know she was, quote unquote, a frequent flyer. But I have to wonder what had been missed, because she died 6 months later of stomach cancer. And the reason she was complaining about stomach pain is she had cancer. And she also looked much different. So each time she went, there were new symptoms and there were new things to catch. And so I really just encourage people to stop and really try to not be so focused on the way someone's acting. We recently had a gentleman who, again, dual diagnosis, intellectual disability and schizophrenia, who he did call 911 because he had a Charlie horse. So we had to talk about that. But he went to, oh man, he got seen at three different hospitals, all for a seizure. And I think they did what was, I think, medically necessary, but there was something else going on and he was very much aware of it. And he ended up having to be intubated. He had a stroke. And so I just want to encourage folks to really think about those things as you serve people who are difficult and who are unhoused. I also want to ask, so you guys are amazing. You're all doing wonderful work, it seems, but is there anything I shared that was new information or changed your perspective or made you think, oh, maybe I'll do this differently? Is there anything you all want to share with one another or me? Because I think it's one of those, I'm preaching to the choir a little bit here, which is wonderful. But is there anything, any new information, anything though that clicked that was like, oh, I wonder if I can do that differently, based on really having the lens of trauma-informed care with those who are unhoused?
Justin said, instead of what's wrong with you, what happened to you, definitely perspective check. I also just want to take a moment to read the comments that came before that question. Dustin said, we are working with the mayor's office in St. Joseph County to coordinate with several outreach organizations to share a writable and updatable map of encampments and demographics. We're able to communicate who is found and what their needs are that need to be met. We're also able to communicate as several organizations with several different areas of reach for care and resources. I'm seeing two. I appreciate the list of efforts listed. That gives us consideration to improve our goals. The health outcomes and diagnosis differences were eye-opening to me. Christine says we use tell me your story, ... Love that. And Julianne says, understand that not all clients even want to be housed. Being compassionate and meeting them where they are is important. Access to personal hygiene is an ongoing issue, and the local truck stop has coordinated use of their facility at reduced cost or free at certain times. The reminder about how many choices these folks don't have and things we take for granted. Absolutely. I thought about that when you're talking about the clothes. And local emergency management leaders are a barrier for warming shelter options and inspired to push for improved access options for those who are homeless.
Thanks, everybody. So I want to give some time for questions, because I'm guessing, and it doesn't have to be about, anything. So let's talk. Oh, just as an FYI, I shared the this nationwide statistics that actually breaks down. You can look in your areas. There's also point in time count data that every community in all of the United States does. And so your balance of state will have the, so balance of state, if you're in Indiana, continuum of care, CHIP in Indianapolis, will have local data and really good information on really a ton of demographic stuff. So that's nationwide statistics. Thought that'd be interesting. Also, I did link to a resource with the National Healthcare for the Homeless Council fact sheet. They have a lot of really fascinating stuff as well. So if anyone wants to dig in, I wanted to make sure you had that.
All right. I'm going to stop sharing so we can see each other. If anyone wants to ask questions, feel free. You can either come off a mute or put it in the chat. I actually realized I did not set up the Q&A feature for this meeting. I apologize for that. But also I will go ahead and throw that link in the chat that was in Lillian's presentation, so y'all have access to that as well.
I also want to offer myself up as in general for anyone who there was a comment made about permanent supportive housing and retention. And that is literally my passion and what we're doing here. And if I can toot my own horn for a moment, our program has much higher than national average on housing retention. So in the event that you want to talk to me about housing retention within PSH, which is permanent supportive housing, please email me. We can chat.
Is your email somewhere
It's a great
easily
question.
accessed here?
I'm putting it in the chat in the event that it's not.
Great, thank you.
Have a question. What would you recommend the kind of average person, maybe not while they're representing their job, but say me in my time off, to kind of help advocate for unhoused folks? What can just the regular person do?
Sure. So I just did a video with a friend of mine who's a ally coach here in Indianapolis. And I think there's many different levels of support people can give. And I think all of them are valid and everybody has their strength. So I think if you are a person that has time or energy to give, volunteering at a place that works on food access, volunteering at a shelter, volunteering at a day center, I think is wonderful. If you are someone who has extra items, find a place that needs them. Most agencies list what they need. So as I'm looking out and it's 15 degrees and there's snow next to me, if you have extra gloves, hats, scarves, coats, I know those are in desperate need, especially probably in everywhere in Indiana right now. So items, resources. If you're someone who wants to give to a nonprofit, give to a nonprofit. If you're someone that wants to work with mutual aid groups and that feels more appropriate to you, I know Indianapolis has many, and they have like resource packing parties together. There's communities who do meals in the park. So time, resources, money is always a thing if you want to give money. And then there's also, I think it's really a really reasonable thing that any of us can do is to try to undo negative things being said about people. So anyone in our lives probably has said disparaging things about unhoused folks. And I think if we can just flip it a little and encourage some empathy, that goes a long way. If you are someone who has any kind of interest in policy, local policy is happening all the time. And there are many different ways in which you can engage in policy that directly impacts people who are unhoused. I'm guessing some of you live in places where camping is illegal. There is new legislation in Indianapolis being pushed through. So Prosperity Indiana and Fair Housing of Central Indiana both have action alerts on their websites, and you can sign up for those. So if you are someone as just a human being who is interested in how policy impacts work, that is something to do as well.
Thank you. It looks like there is a question in the chat. If a client with mental health issues is experiencing delusions, if they are minor, like the date being wrong, is it better to play along or assure them they are wrong even when they are persistent?
So I think a good rule about delusions is that you never tell someone they're wrong. It is their reality. And I know it is probably really difficult, especially in a healthcare setting. But telling someone that that they are experiencing that is super real to them is not real is incredibly upsetting, and it will not help with your rapport at all. So I wouldn't call it playing along. I think that's reasonable to say, but I think I would try to gloss over it. Yeah, I mean that's always been my the rule that we've gone through, and we have that all the time. I mean, and um the re yeah, it gets frustrating, and you won't get very far with that person.
Thank you. Next question. What are your experiences with projects like Voices of the Unhoused, where clients are recorded for their experiences, given a choice about the what and why, and gives people in the community a better look at what it is to be unhoused?
So Justin, I think you're probably talking a little bit about I think that's done by CSH, the Corporation for Supportive Housing. I might be wrong. If I'm wrong, CSH also has one of those. Um, I think it's really important to highlight people's stories in an ethical way anytime we can. So I know what CSH does. It's like a speakers bureau, is that there's some level of training and kind of like a process they go through. I think it's a really, and working at a nonprofit that wants to use stories all the time, and it's a marketing tool. Um, it's always a challenge for me because people will often say, "Oh, I'll do it for you, Lillian," and I'm like, "No, no, no, you don't owe me anything. Please don't." So I kind of follow the idea of, if this is empowering to you and gives you something, then we want to support you in telling your story in a way that feels safe and empowering. And I think that's the key, is that there's no, someone's not doing it because they feel like they owe you, and that it really is about, is this going to be empowering for you to heal from the experience? So that's kind of my take on that.
Thank you. Next question. Can you touch a little on folks without housing who are undocumented, especially with our new legislation? I'm curious about how we can help these folks.
So because all the housing I do is through the housing authority, I don't work with anyone who's undocumented. And so that is an area I have very little information on. What I will say is people who do have good information on that are out there. In Indianapolis, that is Exodus Refugee and Catholic Charities. Those are two. Oh, and Cafe is really knowledgeable about that. That's what does CAFE stand for? I'm not going to remember. I'm so sorry. But my guess is there are other agencies doing that kind of work in the areas you are in, and they are super expertise on those things. I don't want to give any misinformation about that. Thank you, Mary. Community Allegiance of the Far East Side, Indianapolis. They have really good, and there's probably, yes. So I think agencies that do immigration is a really good starting point for that.
Any other questions folks have? I'll give y'all a little more time to think about it. And while you do, I'm going to let you know that I will send out these links that I've put in the chat via email following this. And Lillian, if it's okay with you, I could share your email address as well. Awesome. And I'm going to go ahead and also put the link for the evaluation of this presentation in the chat. If you all could fill that out, that would be wonderful. Helps us inform future events. Okay, that link is in the chat. I'm seeing Derek saying thank you to you. Yes, thank you, Lillian. This was very informative for me. Not a topic that HCT has really touched on since I've been here, so this is really interesting. And I believe if you are a part of the Indiana Primary Care Learning Collaborative, you'll stay on. But if you are not a part of that group, please feel free to jump off. But go ahead and download any links you need, fill out that evaluation. And yeah, we really appreciate y'all being here.
Thanks so much, everyone. Really lovely to know the amazing work happening in and around Indiana. So thank you so much for having me.
Thanks, Lillian. I'll follow up via email.